acute coronary syndrome. Introduction, it's saying that acute coronary syndrome is acute myocardial ischemia and infarction. Ischemia infarction mean the part of that myocardium is dead. Why? Because the rupture of coronary artery atherosclerotic plaque, like this one is plaque, atherosclerotic plaque, this one. So what's happened? It ruptures and there is formation of thrombus like this. Thrombus, what happened? Platelet gets aggregated and there is formation of thrombus. So what this thrombus do? It blockage of blood flow. It causes the blockage of blood flow. If there is no blood flow like this one, so what happened? There is infarction of distal portion. Why? Because there is no blood, there is no oxygen. So this infarction could be of two type. The one is STEMI, ST segment elevated myocardial infarction, and the second one is NSTEMI, that is non-ST segment elevated myocardial infarction. This is basically what we see on ECG. So let's come to its pathophysiology. First one, STEMI, ST segment elevated myocardial infarction. So what's happened? Plaque rupture, so what happened in plaque rupture? Lipid, collagen and tissue factor get lodged like this one. This is atherosclerotic plaque. So what happens when there is rupture? There is thrombus formation. That thrombus may cause fully occlusion of coronary artery lumen. This is coronary artery and its lumen is fully occluded, like there is no blood flow. Blood flow is zero. There would be no blood flow and transmural ischemic injury of myocardial wall, like whole wall including endometrium, myometrium, etc. is injured. And when we saw on ECG, there is ST segment elevation on ECG. So ST segment is elevated on ECG, like I'll show you on my ECG. Like this one is my normal ECG, है ना? Look at this. This is normal. QRS complex and there is P wave, like in case of myocardial infarction. Now look at this one. This is normal baseline and it is above the baseline, above the baseline. But in case of my normal ECG, it is not above, it is on the same line. So there is no ST segment elevation. 1 lead, 2 lead, second, 3, 4, AVR, AVL and AVF, V1, V2, V3, V4, all the way 12 leads. Now which lead is ST segment of which lead is elevated indicate that which part of the heart is infarcted. So we have a mnemonic that is SALI. So in SALI, you can say SALI as well. Septal, anterior, lateral, inferior. You can count on your fingers SL, SALI. Septal, anterior infarction, lateral wall infarction and inferior wall infarction. So if V1, V2 in septal, 3, 4, 5, 6. 5, 6 plus 1 and AVL, and now for I inferior it is 2 and 3 lead, like this one. V1, V2 for septal, V3, V4 for anterior, 5, 6 for anterior and 2, 3 for inferior wall MI. So now this one, which artery is involved? LAD or left circumflex, RCA, or maybe left circumflex. It depends upon either the circulation is right dominant or left dominant, which we will study further. So now come to the NSTEMI, non-ST segment elevated myocardial infarction. It means that on ECG there would be no ST segment elevation. What happened in pathophysiology? Plaque rupture happened, there is thrombus formation, but this thrombus is cause partial thickness infarction, like whole lumen is not occluded like this one. What happens? Small place is left, blood flow through it. It means that it's not completely occluded. Only subendocardium is infarcted, while in case of STEMI, the whole transmural ischemic injury has happened. So on ECG, no specific change on ECG. It means that ECG is not specific for NSTEMI, but it can show ST segment depression plus T wave inversion. But this is not specific that all cases there would be change in ECG. So our choice of diagnosis test is serum troponin. When you do the test of serum troponin, it would be raised. So we have divided non-ST segment elevated myocardial infarction and STEMI into two types, type 1 and type 2. In type 1, the troponin is high due to the partial obstruction. So what happened in partial obstruction? Intracoronary thrombus. It causes partial occlusion and the distal portion does not receive the blood flow and is infarcted. And in second type, the troponin is high. Why? Because oxygen supply demand mismatch. What does this mean? It means that the patient is not having a thrombus rupture. What happened? Patient in acute illness like sepsis, like this one, a patient has first one patient is having arteriosclerosis, है ना? Let me just arrange my setup. Look at this one. The patient has sclerosis, and when there is acute illness like sepsis, so what happened? There is tachycardia. It's not coming in the video, I think. So there is when there is tachycardia, the oxygen demand is high, while the oxygen demand is not meted. Why? Because there is thinning of this intercoronary wall. That's why the troponin is high. What happened in type 1? The troponin is high because there is partial occlusion. In type 2, the troponin is high. Why? Because oxygen demand is not matched. Why? Because there is acute illness. There is no thrombosis but acute illness. There is tachycardia. In tachycardia, why the heart is working more rapidly, so it needs more blood supply, but there is no oxygen demand is meeting, so that's why the troponin is high. Okay, now let's come to anatomy and localization of MI. Suppose a patient is having MI, myocardial infarction. How we locate which place of the heart is dead? Look at this one is heart. It has basically two main vessels. The one is right coronary artery and the left main. The left main is further divided into left circumflex artery and left anterior descending artery. Now left anterior descending artery supply anterior left ventricular wall, this one, septum, intervertebral septum and apex of the heart, while the left circumflex artery supply lateral wall. Okay, the lateral wall of the heart. In 10% cases, inferior wall in left main dominant circulation, the right marginal branch of RCA. This one is right marginal branch of RCA. This one is RCA. It is right marginal branch, while this one it is having the branch sinoatrial nodal branch that supply to the sinus atrium. And the right coronary artery, the RCA, it supplied right ventricle as well as inferior left ventricular wall in right dominant circulation. That is 85% of the people has right dominant circulation, which means that its inferior left ventricular wall that is inside that because it is 2D, while if it is 3D, the beneath portion is inferior wall. It is supplied in 85% cases by RCA. Now come to the pathology. If a person is having MI, suppose this part is dead, so what would be its pathology? Suppose a patient is having MI at 12 AM, है ना? Middle of the night. So what happened in first 4 hours? There is no visible changes on histopathology, while 4 to 12 hours there is wavy fiber and narrow elongated myocyte like this one. Okay, from 12 to 24 hours there is hypereosinophilia, meaning eosinophilia are very much in this portion, as well as pinotic nuclei, means the nuclei of myocyte has shrunken like this one. Okay, next 1 to 3 days there is coagulation necrosis, mean that loss of nuclei. This nuclei which has been shrunken in 12 to 14 hours, now it is completely lost, and there is neutrophilic infiltration. The neutrophil came here and they are dominant in this portion. From 3 to 7 days there is disintegration of neutrophil as well as myofiber. The neutrophil that are infiltrated in 1 to 3 days are now begin to disintegrate. They are now being dead. From 7 to 10 days there is phagocytosis of dead cell. The cell that had been disintegrated are now being engulfed by macrophages like this one. This is macrophage. It is eating that cell, dead cell. There is phagocytosis. From 10 to 14 days there is granulation. when macrophage eat neutrophil, there would be the formation of granulation on 10 to 14 days, from 2 to 8 weeks. Like after that, there is collagen deposition and scar formation. Okay. Again, we'll see from 0 to 4 hours, there is no visible change. 4 to 12, wavy, narrow, elongated myofiber. From 12 to 15 to 40, 24 hours, hypereosinophilia and pynotic nuclei. 1 to 3 days, coagulation necrosis, neutrophilic infiltration. 3 to 7 days, disintegration of nuclei as well as myofiber, while from 7 to 10 days, there is phagocytosis of dead cell, and there is formation granulation and ultimately collagen deposition and scar formation. Now, how patient will present you in a clinic, that's so much important. The first hallmark feature of MI is chest pain. Patient will say, I'm feeling heaviness in my heart, I'm feeling severe pain, and that pain will radiate towards the left arm, towards the left jaw, as well as to the tip of the shoulder. And in 80 to 85% cases, there is pain. It's not saying in 100% cases patient will say, I'm having pain. Okay, so this dyspnea mean patient, there is difficulty in breathing in 70 to 75% cases, while nausea is in 40 to 55% cases, vomiting in 15 to 20% cases, and epigastric pain in 12 to 15% cases. So there might be happen the patient present to you that I'm having epigastric pain as well as nausea, vomiting. So and you have to do the ECG to rule out MI. Okay. The other symptom that can also happen are diaphoresis, mean patient will say that I was having severe sweating as well as fatigue and anxiety. There is another form of MI, that is silent MI, mean there is no chest pain like this one. Patient will present, it is happen in advanced diabetes mellitus patient. While in diabetes mellitus, the neurons, the nerve fiber begin to damage. So there is no pain, nerve fiber. So there is no pain. That is known as silent MI. And there is another form of presentation that is known as atypical presentation, that happen mostly in women and elderly patient. Patient will say to you, I'm having gastrointestinal symptom like I have a constipation, diarrhea as well as bloating, etc. and discomfort in abdomen as well as pain in abdomen. Like there is no chest pain. So this is atypical presentation. Normal presentation is chest pain, dyspnea, nausea, vomiting, epigastric pain, diaphoresis, fatigue and anxiety. But in silent MI, there is no pain. It happened in advanced diabetes mellitus patient, and in atypical presentation is woman, elderly and gastrointestinal symptom with no chest pain. So there is contractile dysfunction. Obviously the heart, this portion of heart, suppose it is dead, now its ability to contract is lost. So it's contractile dysfunction that causes acute heart failure. It is now divided into if involvement of left ventricle, it is left ventricle infarction, and right ventricle infarction. In left ventricle infarction, there is pulmonary edema and respiratory distress. How? I will teach you. Like this one is left ventricle infarction. Now it is unable to contract. So what happened? The blood from atrium comes to right ventricle, and right ventricle is unable to contract. So there is high pressure in left atrium, and the blood that is coming from lungs to the right atrium, left atrium is not coming. So in lungs there is accumulation of edema. There would be pulmonary edema and respiratory distress. While in case of right ventricular infarction, there would be hypotension. On physical examination, there would be S4, S3, tachypnea, the heart rate would be increased, there would be fever, there may be fever, है ना? Why? Because there is infarction, inflammation, and inflammation causes fever. There would be lung crackle when you put on your stethoscope and listen to the sound of breathing, that would be lung crackle, and jugular venous pressure would be raised. So now how will you diagnose a patient present to you with that symptom? How will you diagnose? First of all, there is history as well as physical examination. After that, if you will tell the patient to do ECG, and on ECG, if patient is having STEMI, any ST segment elevated myocardial infarction, there would be ST segment elevation at J point. So what is J point? Normally, suppose this is V1, this is P wave, this is QRS complex, Q wave, R wave, S wave, and there is T wave. So this one is QRS complex and this is ST segment, and this ST segment would be elevated. Like this is normal line, it would be elevated like this one. This is J point, QRS complex, and this is, now this is raised. This is not on baseline, it is raised, है ना? So this is how will you diagnose the ST segment elevated myocardial infarction. Like I have teach you, this is my normal, like this one normal. So like this one normal है ना, on V3 suppose. Now this V3, it is a patient having anterior wall MI. When you watch its V3, it is baseline. Now this is raised है ना, it means that it is having MI, myocardial infarction. Now this one is also having anterior lateral wall MI. Now look at this, this is normal and this is raised. It means that this patient is having myocardial infarction. So ST segment elevated in more than two anatomically continuous leads, like V4, V5 है ना, V1, V2, V3, V4, like this one. More than 1 mm, it means that 0.1 millivolt in all leads except V2 and V3. Like for V2, V3, there is rule is some sort of different. So what's rule for V2, V3? If any other lead having more than 1 mm, two contiguous lead, it means that it is having MI, है ना, ST segment. For V2, V3, the elevation would be more in women, it would be more than 1.5 mm, while in case of men, we divided into two cases. The men age more than 40 and the men age less than 40. If it is having more than 40, then there should be more than 2 mm in men age more than 40, while in case of men age less than 40, there should be 2 mm raised, that of baseline, like this one baseline 2 mm should be raised. So ST segment elevation on ECG is not 100% sensitive. Okay, you have to remember this. So what we'll do, the left bundle branch would be blocked on ECG, isolated ST segment elevation of AVR that could happen, or V1 lead, okay, plus there would be ST depression in inferior and lateral lead. You can't remember this, you just remember what has written, है ना? Now come to the diagnosis of NSTEMI non-ST segment elevated myocardial infarction. First of all, there is consistent clinical presentation. Patient will say to you that I'm having continuous pain in my chest, dyspnea, vomiting, nausea, etc. है ना? Consistent pressure like chest pain. And serum troponin, when you do the serum troponin, it is also high. It began to high within 1 hour of myocardial infarction. Okay, so you will diagnose on the basis of serum troponin. Now the role of echo in NSTEMI, like non-ST segment elevated myocardial infarction, there may reveal localized reduction in wall motion, like this one, if a wall is infarcted, like this one. So its motion is not like same one, है ना? This is how you can detect on echo. While in case of STEMI, ST segment elevated myocardial infarction, you can't do the echo. Why? Because you don't have enough time, because ST segment elevated mean the whole artery is occluded. So patient, we cannot delay the emergency by doing echo, है ना? So we don't do echo in STEMI, while in non-STEMI we do echo. Acute coronary syndrome completed by heart failure, echo can also reveal that there is left ventricular or right ventricular dysfunction. So how will you manage the patient of MI? It's very important. First there is prevention, then is initial treatment. We will see the prevention. Prevention of arteriosclerosis, cardiovascular diseases is divided into further two types, the primary prevention and secondary. Primary, by don't do the smoking. Smoking is the biggest risk factor for MI, for the stroke, for many of the diseases that happen due to the arteriosclerosis. Okay, the second one is diet. Don't eat saturated fat, although the new research is saying that you can eat saturated fat, but according to the conservative diet, less saturated fat. Hypertension, control your, there should not be high blood pressure, control your diabetes mellitus, है ना? While there is no firm indication of low dose aspirin, है ना, you have to eat, but you can use it. As well as low dose statin is in primary prevention, while in secondary prevention, in what patient there would be secondary prevention? The patient that is having established arteriosclerosis, cardiovascular disease. and that patient that is having previous myocardial infarction, stable angina, revascularization and peripheral arterial disease, if patient are having these condition, then there would be secondary prevention. And what is secondary prevention? The lifestyle modification that we have studied, and as well as the PP should be less than 130/80. If it is having up, by take your medicine. Then high intensity statin, use high intensity statin, okay, like rosuvastatin as atorvastatin, okay. And there would be antiplatelet therapy and strict diabetes mellitus control your diabetes. Suppose if a patient is having MI, what would be the initial treatment? Initial treatment is again divided into, if there is STEMI or non-STEMI, ST segment elevated myocardial infection or non-ST segment myocardial infarction. In STEMI, there would be coronary reperfusion within 90 minutes of first medical contact. Suppose a patient come to you in emergency, so within 90 minutes you have to do the coronary reperfusion, okay. What is reperfusion? Percutaneous coronary intervention. You have to do the angiography and place the stent like this. If it is blocked here, this is vessel, you do the catheter, pass the catheter, and there would be inflation of this balloon like structure that we known as stent, so that the blood flow should continue, okay. In non-STEMI, you have to do the coronary angiography within 24 to 48 hours. It means that STEMI is more emergency situation rather than NSTEMI. But you have to do the immediate if patient is in shock, if there is a refractory chest pain, like chest pain is not relieving, and if there is ventricular arrhythmia, then you have to do the immediately coronary angiography. So how will you manage medically? Which medicine you will give? It is divided into 5 types. The first one is nitrite, like nitroglycerin. What this medication do? It causes venous dilatation, and there would be less venous return to the heart. And if there is less venous return to the heart, and heart has to pump less effort. Why? Because there is less venous return, so the oxygen demand for heart is low. So that's why you gave nitrite, but it is contraindicated. You don't give nitrites like nitroglycerin in patient with right ventricular infarction, okay. So if patient is having right ventricular infarction, you don't give nitrites. Second one is beta blocker like metoprolol. What these medication do? It reduces heart rate plus contractility, heart rate as well as contractility. So oxygen demands is less of that heart muscle, and there is less chances of ischemia. Then there is dual antiplatelet therapy, in which there should be low dose aspirin plus P2Y12 inhibitor like clopidogrel. What this medication do? It causes less risk of thrombus formation. But you are not going to do it if there would be surgery of the patient, before 5 days of surgery. You are not going to give patient this antiplatelet therapy. Why? Because in surgery there would be bleeding. Third one is anticoagulation like heparin, bivalvuridine and enoxaparin. It decreases the risk of thrombus expansion. And fourth one is high intensity statin. It stabilizes the plaque, like this one. If there is plaque, this one is plaque in artery, so it will stabilize, it will not cause it to rupture, And the last one, this one, nitrites, beta blocker, dual antiplatelet therapy, anticoagulation and high intensity statin. Now there is special consideration for right ventricular MI. So first we will see what is the difference between left ventricular MI and right ventricular MI. In left ventricular MI, the clinical feature is pulmonary edema as well as S3, S4 sounds. Why? Because if left ventricle is not able to contract, so blood will accumulate in lungs, so there would be pulmonary edema. While in case of right ventricle MI, clinical feature would be clear lungs plus there would be raised jugular venous distension. Why? Because if this right ventricle is dysfunction, it is unable to contract and blood will accumulate in this portion as well as in this portion, right atrium. So blood from the system won't come here. Why? Because it is not contracting its own blood. So there would be jugular venous distension as well as marked hypotension. Why? Because if it is pumping less blood into the pulmonary, into the lungs, and there is less return into the left atrium and as well as left ventricle. So if preload of left ventricle is less, it would the cardiac output would be less, and there would be marked hypotension in right ventricular myocardial infarction. On ECG, on left ventricle MI, there would be ischemia in anterior, lateral or inferior lead, while in case of right ventricle, just inferior ischemia, ischemic changes, and ST segment elevation in V4 or lead. On hemodynamic finding, on left ventricle MI, the left ventricular as well as right ventricular preload is increased. Why? Because there is accumulation of blood, so preload is increased. While in case of right ventricular MI, the right ventricular preload is increased, but left ventricular preload is decreased. Why? Because this right ventricle is not pumping blood into the lungs, and there is less return to the left side, and that's why left ventricle preload is decreased. The management of left ventricle is fluid restriction. You don't do the fluid, and as well as decrease the preload and afterload reduction. But in case of right ventricle, it's very, very important. There would be fluid resuscitation. You give the fluid to the patient, as well as avoid preload reduction. Why? Because if there is preload reduction, the left ventricle won't pump the blood enough to the circulation, and there would be hypotension would further severe. Like this one, if there is right ventricular MI, the right ventricular contractile dysfunction, okay, the right ventricle is unable to contract, so right ventricular preload is increased, and the right ventricle cannot pump the blood. So what happens? The left ventricular does not receive the blood from lungs, as well as its preload is decreased, so there would be marked hypotension. So that's why you don't give nitrites, diuretics and opioid to the patient. It is contraindicated in right ventricular MI. It's very, very important to remember. The reason explaining all this is this one. You don't give nitrites, diuretics as well as opioid to the patient having right ventricular MI. So when will you place the stent to the patient? When it is having single vessel disease, like it may be any of the vessel, like LAD, RCA or left circumflex, as well as two vessel disease in which suppose RCA or left circumflex is involved, then you do stent placement. When you do CABG, what is CABG? CABG is coronary artery bypass graft. It is surgery in which you open the sternum like this one, and there is a graft, graft placement. Its indication is two vessel disease involving LAD, left anterior descending, in the patient with diabetes mellitus. Patient is having diabetes mellitus. It is also involving two vessel. One vessel is LAD, so you will go for CABG. In three vessel disease, and the third one is most left main artery disease like this. This is main artery. It is further divided into left circumflex and LAD. So if there is infarction here in main artery, then you go for CABG. So what are the complications? The first complication of MI is ventricular arrhythmias. There could be ventricular tachycardia as well as ventricular fibrillation, high risk. It is most common cause of death in MI. In most patients, why patient die? Because of ventricular arrhythmias. The second complication is bradyarrhythmias, like sinus bradycardia as well as atrioventricular block, is common. I'll teach you how. Inferior MI, RCA, if RCA, right coronary artery, is blocked, because right coronary arteries supply blood to the sinus node, atrioventricular node, and if there is no supply to this node, they don't work, and what happens? There would be bradycardia like this one. So right coronary artery, if there is occlusion of this part, its branch is supplying to the sinoatrial node, sinoatrium, and its one other branch is supplying atrioventricular node. If there is blockage, there would be no node, so if there is no node, then there would be bradyarrhythmias. The third complication is, although it's mechanical complication, although it is rare, but can happen. what are these complications? The first one is papillary muscle rupture. The second one is interventricular septum rupture. Like if it is this septum, it would be rupture, so blood will come from here to here. The third one is left ventricular free wall rupture. Like if it is left ventricular wall, it would rupture and blood will come into the pericardium. The last one is left ventricular aneurysm. There would be aneurysm and like this one of left ventricle, है ना? So these are complication of MI, myocardial infarction.